And what do you guys think of this lesion? Just over a centimeter. So does anybody have any thoughts?
I'm thinking it's faintly hyper-enhancing and washing out.
Right. So that's when I start reading the case, I was like, oh, well, this cute little LIRADS 5. Then I start looking at every sequence, as we all should. And
right.
So it was a very interesting fake out of a. So this is just a very pertinacious or hemorrhagic cyst. It was very bright on T1, and because of this intrinsic brightness, if I just show you the arterial and portal venous phases, it mimics hyperenhancement and washout. So it remains hyper intense to the parenchyma because the parenchyma didn't really gain signal yet. And then it looks like it washed out because the parenchyma increased the signal, but the lesion really didn't change inside. So it was just a cute little fake out. And obviously this is not something that anybody would be fooled by, because you're never gonna in real life read the case without looking at T1 and T2 and everything. But you can see how if somebody just shows you arterial and portal venous phases, you can get fooled by thinking that you're dealing with enhancement washout.
That is cute. I sometimes get fooled not when it's like a cyst like this, but when it's a T1 bright nodule that has, mild enhancement, and then it looks like it has a lot of washout, especially on the subtractions. And then I kind of have to debate, like, is it truly hyper enhancing and washing out and, kind of subtracting out that T1 hyperintensity. Do you know what I'm talking about? Does that make sense?
Yeah. Yes. So what you're describing is much more common, right? Because mildly T1 or intrinsically T1 hyperintense nodules are quite common in livers. So then at those points, you want to look at the subtraction images to figure out if there's enhancement, if it's enough to get called hyperenhancement. But I think in here, like the T2 just pretty much cinched the diagnosis. So we didn't have to look at the subtraction, but in subtractions, of course, you see that there's no enhancement.
Yeah.
So, right. So you're right. So this is a very unusual fake out. Usually we don't. Something else fakes this out. But anyway.
Cool.
Okay. Those are my cases.
Is Gitanjali there? Let's see. Oh, Victoria, actually, I got a question. It's a LIRADS related question. So do you use specific criteria to call fatty liver on contrast enhanced CT? On the 2018 LIRADS manual, it says to call it if the liver is greater than 10 Hounsfield units below spleen, but different radiologists have told me different things. So,
right. So
can we use the post-contrast liver versus spleen to call fatty liver?
So unfortunately, it's unclear. But I think there's an error because the difference in 10 is on an unenhanced CT. On the enhanced CT, the criteria is much less accurate because the difference in liver and spleen is going to depend on amount of contrast you're going to use, type of contrast, the phase of injection. Generally, people accept if the liver is 30, 40 Hounsfield below the spleen, it's okay to call. But I've seen cases where you look at it looks really fatty, but then you look in the pre and it's not. So you just
the post contrast seems much more unreliable. So maybe that won't.
So unless. Right, but you also want to look at other things, like if the liver, is very heterogeneous, and you see areas which are clearly, more spared, so you would use other things to be more confident that you're dealing with fat. So if you see like areas of focal theta sparing, it'll be more comfortable, you know, to call something fatty, but it's difficult. But usually people use at least 30, 40 pounds of difference.
Cool. Thank you.